We'll cover now Chapter 5 in the OpenStax Anatomy and Physiology textbook entitled The Integumentary System, the Skin. Of course, you see the website that anyone can go to and get a free copy of this Anatomy and Physiology textbook. The skin is a vital part of a person's life and their appearance. Some people choose to embellish it with tattoos, makeup, piercings of different types. It's a multi-million-dollar a year industry that we have out here in the care of our skin. A lot of us older people want to keep it looking young. Women spend a tremendous amount of money, and nowadays men as well, to have the skin, particularly in the face and the hands, look very, very nice at all times. Here are several YouTube links that you need to go to and watch. It gives you a lot of nice animations about the skin. It gives a nice synopsis about the skin, the integumentary system. So these YouTubes I want everyone to watch. The integument, skin. So it consists of two distinct regions, the epidermis and the dermis. The epidermis is that superficial region, and it's made of epithelial tissue. Remember, epithelial tissue is avascular. The dermis then underlies the epidermis, because epi means above the dermis. The dermis is mostly fibrous connective tissue. And then we have the hypodermis, which is also called the subcutaneous layer. That's some places where we give a sub-Q injection. It's also called the superficial fascia. This subcutaneous layer is deep to the skin, so therefore it means it's underneath the dermis. It's not part of the skin, but it shares some of the functions of the skin, and from a functional standpoint, it's almost impossible to think about the skin without considering the hypodermis, aka subcutaneous layer. This hypodermal area is mostly adipose tissue. It's there to absorb shock and to help to insulate the body. It's also used to anchor the skin to the underlying structures, mostly the muscles and some additional fascia planes in the body. Figure 5.2 in the textbook shows you the layers of the skin. We start from the most superficial layer. We see the epidermis, the dermis. That's the two layers of the skin proper. Then the hypodermis. We will see the different accessory components of the skin, where they're located. We see within the dermis, we have the muscle attached to the hair that allows it to stand up under sympathetic innervation, the hair follicle itself, the many sebaceous oil glands that are associated with the hair follicle, the hair root, and the receptors around the hair root. Now, they're actually hair shafts. Yeah, they're not innervated, and that's how come we can shave and cut the hair and we don't feel anything, because we're cutting the component of the hair in the skin above where there's any kind of innervation. The hair shaft is all dead keratinized tissue. We see the fat down in the hypodermis area and the main blood vessels going to the upper layers of the skin. So we have within the dermis the vascularity, because remember the epidermis, which is epithelial tissue, is avascular. So it's going to get those living cells, and the layers we're going to talk about will get their nourishment and get rid of their waste product via the blood vessels in the dermis that comes from the hypodermis. The epidermis is keratinized, stratified, squamous epithelium. So we have 4 or 5 distinct layers of this depending upon what part of the body we're talking about. Most of the body has what we call thin skin, which is 4 layers. In the palms of the hands and the soles of the feet, we'll have 5 layers, and there we're going to call it thick skin. But of the 5 potential layers there, we have from the bottom up to the top of the skin, the stratum bacilli, stratum spinosum, stratum granulosum, And then that additional area in the palms of the hands and the soles of the feet is the stratum lucidum. And then the most superficial part, the part that's been sloughed off all the time and that we view, which is totally dead keratinized tissue, is the stratum corneum. We're going to find 4 cell types in the epidermis: the keratinocytes, the melanocytes, the dendritic cells, and the tactile cells. Dendritics is the Langerhans cells, the tactile cells for touch, and also the Merkel cells. Figure 5.4 shows us a nice micrograph of a piece of epidermis. And as we stated, the epidermis is epithelium tissue composed of several layers of cell. The basal layer is going to be cuboidal cells, whereas the outer layers are squamous keratinized cells. So we're going to say the whole epithelium of the skin will be described as being keratinized, stratified squamous epithelium. One should remember when we name epithelial tissue, it's got 2 names. One, whether it's a single layer, such as simple, or multiple layers, which means 2 or more. And certainly the skin is more than 2 layers. We're going to see it goes anywhere from about 30 to 50 layers thick. So it's stratified. The other name of the epithelial tissue, remember, is the shape of the cell: cuboidal, cube shape, columnar, column shape, or flattened squamous. And we said that we'd always choose that shape based upon the apical side, the top side, the outer side of it. So the very top layers of the epidermis here are flat. So we're going to call this stratified squamous epithelium, because we have a particular protein in it to make it tougher and water seal like, which is keratin. We're going to call it keratinized stratified squamous epithelium. Back to those 4 cell types of the epidermis. We have the keratinocytes or keratinocytes. Separate ways you can say that depending upon what region of the country you're from. These produce then, as the name would indicate, that fibrous protein keratin. And most cells of the epidermis are keratinocytes. They're tightly connected by those desmosomes. So the skin, remember, is epithelial tissue, very little material in between it. So we want those cells sort of sewn together tight, so as to keep microbes and things in the environment from being able to penetrate through the skin to get inside the body, and for us to prevent water leaving the body so that it doesn't become dehydrated. The melanocytes, they will make up about 10 to 25% of the cells in the deepest part of the epidermis. They produce the pigment melanin, and then that melanin is going to be packed into little bodies called melanosomes. And of course, melatonin is there to protect the apical surface of the keratinocyte's nucleus from ultraviolet radiation from the sun, so we don't hopefully wind up with some type of cancer. Dendritic cells are these special macrophages. They're part of the white blood cell system, and you'll find when you take a course in immunology, they can be key activators in the immune system. Those particular macrophages in the skin we call Langerhans cells. Then we have some cells, we'll see a picture in a moment, called tactile cells. They allow for sensory perception, us to be able to touch and feel things in our environment, touch the tabletop, touch that nice soft piece of clothing that we might have. So there's sensory touch receptors, and here we're going to call them, named after the person that first noted them, Merkel. So they would be Merkel cells, tactile Merkel cells. Another tactile receptor in the skin is the Meissner's corpuscle, where the tactile mercurial discs are tonic receptors for light touch, thought to sense the textures, edges, and shapes of things. The Meissner's corpuscles are phasic receptors for light touch and texture. They occur in the dermal papilla of the skin, and they're especially concentrated in the sensitive, hairless areas such as the fingertips, palms, eyelids, nipples, and lips. And you can take and scrape your fingernail lightly across the back of your hand and then scrape across the palm. You'll be able to appreciate the difference in sensation that you feel, and that's because of the high concentration of the tactile corpuscles in the palm area, the palmar skin. Tactile corpuscles will enable a person to tell the difference between silk and sandpaper just by lightly strokes of your fingertips over the two types of material. So we talk about the deepest epidermal layer of the epidermis is the stratum basale or stratum basale, whichever way you want to say it. That's the basal layer. It again is the deepest epidermal layer, also called the stratum germinativum. That is the very mitotically active site. That's the layer of cells that's going to constantly be reproduced through mitosis and replenish our skin. This layer is firmly attached to the dermis, so it's a single row of stem cells, multipotent stem cells. Again, it's actively mitotic. It's going to produce its daughter cells, and it's going to take then about 25 to 45 days from that cell to find its way to the very top of the skin. And we're going to see it's going to have this programmed orderly death as it moves towards the surface. Now, of course, one of the two cells are going to remain there as a stem cell to make additional cells. The melanocytes compose, as I've stated earlier, 10 to 25% of this layer of the epidermis. The stratum spinosum, or the prickly layer, it's about 5 to 10, 7 to 9 layers. Cells here are going to contain these web-like systems of intermediate prekeratin filaments attached to desmosomes. Got a lot of little bodies of melanin here produced by the melanocytes in those melanosomes. And here's where you're going to find the dendritic cells as well. We really get that prickly or spiny look based upon staining process, where the cells have anchored together with the desmosomes, and then when they're dried out, when they're dead, because there has the plasma membrane still attached and they're sort of shriveling up, it gives you that microscopic view of those appearing to be spiny. But normal skin that's alive, if you could view that then microscopically, it wouldn't have that appearance. The stratum granulosum, so named because it's going to look granular, it's going to have some granules throughout it, is 4 to 6 or so layers thick. Here the cells are going to change drastically in their appearance at this level. They no longer really look cuboidal. They're starting to flatten out. You're going to start to see then the cells, nucleus and organelles start to degenerate. And then here's where we're going to have true keratinization to begin. In other words, the cells are going to start to become just bags of this keratin in them as it goes further up. The cells accumulate keratinohyaline granules. This helps to form the keratin in the upper layers. It also will see the cells here accumulating what's called laminar granules, and these are water resistant glycolipid proteins that will slow water loss there. And the cells above this layer then will definitely will be dead. They're no longer living, because now we're getting further and further away from the dermis, which supplies the blood supply, which gives cells oxygen and nutrients it needs via diffusion. And now these cells in this layer, particularly the next layer, they're so far away that diffusion can't take place. They start to die, but they die in a purposeful way through a process called apoptosis. So it's not like necrotic tissue that will cause a inflammatory response. These are dying in a program, purposeful way, and we don't have an immune response, an inflammatory response induced. Now, if we're talking about the palm of the hands or the soles of the feet, we're going to see another layer called the stratum lucidum, the clear layer, and all. It's only in what we call the thick skin at those locations. It's translucent. It looks translucent band superficial to the granulosum, and there are just a few rows of flat dead keratinocytes here. Now, some anatomists would argue that it's not really a distinct layer. It's a layer where we have increased tension and stress because of us picking things up in our hand and the weight in the bodies on the soles of our feet. It is really just sort of a transitional area to the last layer, the skin. But right now, we say that there is this additional layer in these areas of skin called thick skin. Here it shows thin skin versus thick skin in figure 5.3. So we take A is thin skin, and then B is the thicker skin. So you can note that significant difference in the thickness and the epithelial layer of the thick skin. So the most superficial layer, the layer we look at of the epidermis, is the stratum corneum, the horny layer. It's somewhere between 20 to 35 or 40 rows of now definitely dead, flat, anucleated, keratinized, membranous sacs. That's basically what they are. Just sacs of this keratin material. 3/4 of the epidermis thickness is of this layer here. Now, even though these cells are dead, they've got a purposeful, functional activity to provide the body. They're going to protect the deeper cells from the environment. They're going to protect the body as a whole from water loss. They're going to protect us from abrasion and penetration. Certainly going to protect us against by forming a barrier against biological invasion from microbes, bacterium, viruses, fungi, things such as that. Protect us from chemicals that would in the environment that would possibly get into the body and disrupt other cells. And all gives us, along with the rest of the skin, some thermal regulation. Certainly, it provides for the hairs to come through to give us some communication with the environment, so we can feel things on our skin, and along with those tactile receptors. So, just though it's dead, and that's basically what we look at person. Most of what we see in a person when we look at them is dead tissue. Even though we spend a lot of money to make that dead tissue look attractive, it has a very necessary purpose to it. So from the beginning, at the basal layer up, we see cell differentiation in the epidermis. So we're going to see the cells change from that stratum basilae to the stratum corneum, and we're going to have this accomplished by that special form of cell death that I alluded to earlier, apoptosis. So this is controlled cellular suicide. So we see the nucleus and organelles break down, the plasma membranes thicken. This allows the cells to slough off as dandruff and dander, and we shed about 50,000 cells every minute. And that's 50,000 cells every minute that has to be continuously replaced by that mitotic activity of these cuboidal cells, predominantly cuboidal cells, in that stratum bacilli. So our body is busily replenishing our skin for the reasons that I've said earlier. So figure 5.5 gives us a nice pictorial view of the skin, the layers of the epidermis. Here we're looking at thick skin because we got the stratum lucidum there. So we see the corneum with the dead cells filled with keratins, already some sloughing off. We see the stratum granulosum with the laminar granules in it, the spinosum here, the keratinocytes in them, the bacilla. We see with the Merkel cells and the melanocytes in it, and of course we'd expect to find up in the spinosum some of the dendritic cells. The second part of the skin is the dermis. It's strong, flexible, connective tissue. Cells we find there would be the fibroblasts, macrophages again, occasionally some mast cells, and some other white blood cell types. So we find the fibers in a matrix there that's going to bind the body together. Basically, the dermis is what we call the hide, and that's what people in some other animals would use to make leather. Here we got a lot of nerve fibers, the blood supply that, remember, the main blood supply, then branches of it's going to go into from the hypodermis, and a lot of lymphatic vessels. Here also we'd find the epidermal hair follicles along with the oil and sweat glands. The dermis has two layers, the papillary and the reticular layers. So figure 5.7 shows the layers of the dermis. So this is a stained slide that's showing the papillary layer and the reticular layer. And then of course on top of that we'll see the serrated looking bacillar layer and the other layers of the epidermis. In figure 5.14 we see the skin with some eccrine glands being represented in it. They're cord glands in the dermis that release sweat, which is mostly water. The papillary layer has areola connective tissue with collagen and elastic fibers and blood vessels in it. We consider it loose tissue. We also find phagocytes there that patrol looking for microorganisms that might have breached the layer of the epidermis or somehow has migrated from some other foci in the body where they're traveling. The papillary layer has what is called dermal papillae. That's superficial peg-like projections up into the epidermis. So in these dermal papillae, we're going to find a lot of capillary loops so as to ultimately give the blood supply to the epidermal tissue, particularly that stratum bacilli. We're going to find in these little papillae, nipple-shaped projections into the epidermis, some of the Meissner's tactile receptors. We're going to see some free nerve endings, nociceptors, pain endings. And in thick skin, down on their fingertips and all, and their feet, it's going to lie atop dermal ridges that then cause epidermal ridges. And then collectively, these epidermal ridges gives the what we call friction ridges, and they're there to enhance gripping ability, our ability to hold on to things, such as a pencil manipulates the things. They contribute to the sense of touch, particularly vibration and other things, and they're patterns then that makes what we call fingerprints. That's then when we touch a surface, because of some of that oil and all in the skin, it leaves behind where those epidermal ridges are formed, and then that configuration of those together gives us our fingerprint or footprint and all. So we see the baby being born, we got a nice little footprint of the baby. Second layer of the dermis is the reticular layer. It's about 80% of the dermal thickness. It's dense, fibrous, irregular connective tissue. And it's going to have some elastic fibers in it that provide some stretch and recoil properties to the skin. So when we bump up against things, or we take and we can pull our skin up, it's going to then recoil back down until we get older, and we're going to lose some of that elastic fibers and all. It has collagen fibers that gives the strength and resiliency to the skin. That's going to bind water as well. It's got these cleavage lines that are there because most collagen fibers run parallel to the skin surface. We can't see those externally, but the surgeons who operate know their general pattern, and so they want to try to make an incision parallel to the lines so there's less gap in the skin then when they cut into it, and it gives the healing process for reasons. It makes it a little quicker and less likely then to leave behind any noticeable scar as well when after the surgeon sutures the incision up. We got some skin markings to the skin as well. We have what's called flexure lines. They're dermal folds near the joints. That's where the dermis is sort of tightly secured to the tighter structures, the muscles and the little joint capsules underneath. And there the skins can't slide as easily for joint movement. Thus, as we move them, it causes these deep creases and all. So they're visible on the hands, wrists, fingers, toes, and soles. That's sort of what the palm reader will read and say, look, you got that long lifeline or a line of prosperity. And so if you take and look in the palm of your hand and sort of barely flex your fingers and all, and you'll see those dermal folds to develop. Skin color. 3 pigments contributes to the ultimate color of our skin. The main one is melanin, and that's a pigment that's made in the skin by the melanocytes, keratin, and then hemoglobin, the hemoglobin molecule within our blood. But the main determinant really of the color of our skin is the amount of melanin produced by the melanocytes in the stratum bacilli, and then how much of what's produced is taken up by the keratinocytes. So it doesn't matter if you're a black person or a Caucasian or what. The ultimate, we all basically have the same number of these melanin producing cells, but for a multitude of reasons, genetics depends upon how much melanin these melanocytes produce, and then how much is taken up by the keratinocytes in the skin. And of course we have melanin in the back of our eyes and in other places as well. So there's 2 forms basically of melanin, the reddish to yellow to brownish to black, and the skin color is different again due to the amount and to the form of the melanin produced. So we see the melanin is going to migrate from the melanocytes and those melanosomes to the keratinocytes to form the pigment shields, which is there ultimately to help protect the nucleus of the cells from ultraviolet radiation from the suns. Freckles and pigmented moles are just local accumulations of the pigment. Sun exposure stimulates melanin production. It takes a little while for that to take place, so we get our tan to develop over several days. Now, what we call sunspots, tinea versicolor, actually is a fungal infection, and it's not related to melanin pigment. Now, keratin then is that a yellow to an orange pigment, and we see it most often in the palms and soles of the feet. It accumulates in the stratum corneum and in the hypodermis. There it can be converted in the skin to vitamin A for vision and epidermal health. A lot of the yellowish tinge to some Asians is due to a larger concentration of keratin and melatonin variations. Hemoglobin then will cause a pinkish hue in someone's very fair skin based upon how much oxygen is attached to that hemoglobin molecule. There are some people who have problems with the color of their skin. One is vitiligo. That is depigmentation in just spots. And there's different forms of vitiligo, and it can be caused from a genetic problem or an immune system problem and some other problems. But usually it is depigmentation. In other words, the melanocytes are not producing the melanin like they should, and this gives us lighter colored patches of the skin. And fortunately, there's some treatment for people because it can be very disappointing to people, cause a lot of social anxiety. It's not a very serious disease in that it's not going to kill you or impair any of your activities of daily living, but it can cause some psychological problems and challenges with the individual. We can use skin color in making a diagnosis or for diagnostic purposes. And at one time, the doctor giving an examination, they looked very closely for change in skin color, particularly in the nail beds and around the mouth and different areas. It's not quite a developed skill as it used to be. And I think it should be maintained in this. But anyway, so we can look at what appears to sort of be blue colored skin, cyanosis. That's when we have low oxygen levels in the blood. We don't have the hemoglobin molecule attached to adequate amount of oxygen molecules. Erythema, redness, we can get that from fever, too much exertion outside, hypertension, severe hypertension. A lot of people can have some very bad hypertension, malignant hypertension, but still not have the red face, inflammation, allergies, and things such as that. Pallor is blanching. It gives you that sort of whitish look. You can get that for people with anemia, very low blood pressure, fear and anger, and jaundice, the yellow cast from bowel pigmentation building up because of liver disorders, gallbladder disorders, a bronzing looking appearance because of inadequate steroids, particularly involving the adrenal glands, in a disease called Addison's disease. Any kind of ecchymosis or bruises where there's clotted blood underneath the skin. Now we look at some of the accessory parts of the skin or appendages of the skin. All of these actually are derivatives of the epidermis. In other words, it's the epidermis where we get them from which we get them formed, such as the hairs and hair follicles, the nails, the sweat glands, and sebaceous oil glands. Now, each of these is going to play their own unique role in maintaining the body's homeostasis. Because really, everything is about maintaining homeostasis, correct? All these systems working together to maintain total body unit homeostasis. Everything in that nice little Goldilocks range. Not too much, not too little. So not only do we stay alive, but we feel good. We're healthy. Now, hair, also known as pili for plural. It's dead keratinized cells of the hard keratin type produced by hair follicles. And usually a follicle is a little histological entity that produces something, like follicles in the ovaries produces the mature oocyte or secondary oocyte is going to be ovulated, or the follicles in the thyroid gland is going to produce thyroxine hormones and all. So these then are dead keratinized cells of the hard type produced by the hair follicles. They're more durable than the softer keratin that we'll find in skin. Of course, we don't find hair in the palms, the soles, the lips, the nipples, and other portions of the external genitalia. If we had hair in the palms, then it'd be harder to grasp things, to hold things, manipulate things around about. Its functions includes the main one being now the warning of insects on the skin before they might can bite us and all, or something that we've lightly touched up against that we're concerned about. So it's a form of communication with the environment. On the head, the hair is going to protect from physical trauma, heat loss, and certainly help to protect the skin there that is in direct pathway of ultraviolet radiation. Eyelashes helps to shield the eyes. The hair in the nose filters the air that we breathe in. The hair pigments, we have the melanins, the yellow, rust, brown, black. Another one, trichosiderin for red hair. We find people like me now, this guy, the white hair, gray hair, due to decreased melanin production, and then we're going to replace that with air bubbles in the shaft of the hair. So the hair follicles, they're going to extend then from the epidermal surface to the dermis. And there are two layered walls to it. Part is dermis tissue and part is epidermis tissue. At the end of it, we have the hair bulb. That's the expanded deep end of the follicle. So, it's just, we say at this rounded, expanded area of this tissue, we're going to call it the bulb. Down here, we have the hair follicle receptor, which is also called a root hair plexus. It's a notosensory nerve endings that we're going to use as a touch receptor. And the hair matrix is the area in the follicle where we have active mitosis taking place. So the production of the root of the hair and ultimately the hair shaft that we see, which is like the top of the skin, the corneum, is dead keratinized tissue. The erector pili is a smooth muscle attached to the follicle, and it is under control of the sympathetic nervous system. So when we have fear or cold, it'll contract and make the follicle change position, will then make what we see on the surface of the hair sort of stand up. So I said, look at this hair standing up. Used to, that was good when we were completely covered with hair, so as to raise it up and make the hair shafts more layered for better insulation, and all. Animals do that for thermal regulation. Of course, we don't do that any longer. We use clothes and everything for that, right? And then the hair papillae, that's dermal tissue where we're going to find the blood supply is provided, and it's going to protrude into the hair bud. So we look at figure 5.11. See a nice picture of a section of the skin, the epidermis, the dermis, and the upper part of the subcutaneous layer, and with the hair and the hair follicle. So hair is just this keratinous filament that's growing out of the epidermis. And again, I said it's primarily made of dead keratinized cells. And the hair is going to originate in the epidermal penetration of the dermis, which we call the hair follicle that we see here. The hair shaft then is part of the hair that is not attached to the follicle. And of course, most of this is going to be exposed on the skin surface. The rest of the hair is going to be anchored in the follicle, and that's going to lies below the surface, which lies below the surface of the skin, and we're going to call that part then the hair root. The hair root, as we can see in the picture, ends deep in the dermis at the hair bulb. And there's a layer, and this is a layer of methodically active basal cells. We find that layer called the hair matrix. And the hair bulb surrounds the hair papilla, which is connective tissue containing the blood capillaries and the nerve endings from the dermis. Now, just at the basal layer of the dermis forms the layer of the epidermis that gets pushed into the surface as dead skin on the surface. It sheds. So will the basal cells of the hair bulb divide and push cells upward into what we call the hair shaft, hair root, and then the shaft as hair grows. Now, the medulla is the central core of the hair. It's surrounded by the cortex. And that's a layer of just compressed keratinized cells that's covered by an outer layer of that very hard keratinized cells known as the cuticle. Now, the layers we sort of see depicted in this longitudinal configuration. Hair texture, whether that be straight or curly, we're going to find is going to be determined by the shape and structure of that cortex we see here, and to the extent that is present, that being the medulla. The shape and the various structures of these layers will in turn be determined by the shape of the hair follicle. And then the hair growth itself was going to begin when the keratinocytes by the basal cells of the hair bulb are produced. Now, as new cells are deposited at the bulb, sounds like we're talking about the skin, right? The hair shaft is pushed through the follicle towards the surface. Keratinization is going to be completed as the cells are pushed to the skin surface to form that shaft of the hair that we see. So the external hair, just like the external skin, is completely dead and composed entirely of keratin. And that's the reason I said earlier, skin is not going to have, or hair is not going to have any sensation. We can cut it and all. We don't. That doesn't cause any pain, and it doesn't cause any structure because the living tissue is deep, the hair is superficial as well. Now, this picture doesn't clearly show it, but the wall of the hair follicle is made up of 3 concentric layers of cells. We got cells of the internal root sheet. It's going to surround the root of the growing hair, and it's going to extend up to the hair shaft. They're going to be derived from the basal cells of the hair matrix. The external root sheet, which is just an extension of the epidermis, encloses the hair root. It's going to be made up of basal cells at the base of the hair root, and it's going to tend to be more keratinous in the upper regions. We don't see it in the picture here, but there is a glassy membrane, which is a thick, clear connective tissue sheet covering the hair root and is connecting it then to the tissues of the dermis. Hair growth. So hair grows, will be shed and replaced by new hair in cycles that occur in 3 phases: anagen, catagen, and telogen phase. In the anagen phase, that's going to be the active growth phase of hair, the active hair growth cycle, and it precedes catagen and telogen and all. So there we got rapid mitotic division and differentiation of the cells in the lower portion of the hair follicle. And this then is going to get us lengthening of the hair shaft. And this usually phase lasts about 2 to 7 years. At any given time, somewhere between 80 and 90% of the hair follicles will be in anagen phase. The catagen phase, that's a short transitional phase of hair growth, of the hair growth cycle between anagen and telogen. Usually lasts 10 to 20 days, 2 to 3 weeks, and that's the point where the lower portion of the hair follicle regresses and hair growth ends and all. Then finally, during the telogen phase, the hair follicle is rest and no new growth occurs. Scalp hair spends about 4 to 8 years in anagen and just about 2 to 4 months in this telogen phase. So, and then we're going to have the hair to come out and fall out, which is really, some textbooks you'll see a phase called exogen. That's actually when the hair falls out of the follicle. So we got the basal cells and hair matrix after the telogen and exogen phase. It's going to produce a new hair follicle, which is going to push the old hair follicle out as the growth cycle repeats itself. Hair is going to typically grow at the same rate of about 0.3 of a millimeter per day during the anagen phase. On average, 50 hairs are lost and replaced per day. And of course, that's going to depend upon a person's nutritional status, hormonal status, and overall health status. So hair loss can increase hair loss for a lot of different problems, a lot of different things take place. People with hyperthyroidism, hypothyroidism, different things, they'll suffer from hair loss. And of course, as we get older, people tend to lose hair because of a lessened amount of anagen phase that will occur. Types and growth of the hair. We have the villous hair, that's that pale, fine body hair on children and adult females. Terminal hair, that's that coarse, longer hairs of the eyebrows and scalps. At puberty, this type of hair is going to appear in the axillary and pubic regions of both sexes, and of course on the face and necks of males. As I've already stated, nutrition and hormonal conditions affect hair growth. On average, we said a while ago, about 0.3 millimeters per day, or somewhere around 2.25 millimeters growth per week. And again, we're going to lose somewhere around 50, maybe up to 90 scalp hairs daily. Hair thinning and baldness then. We have alopecia, that's hair thinning in both sexes after age 40. Usually because of nutritional reasons, and we just start to wear out. Now, true frank baldness, that's going to be genetically determined and sex influence, and is a sex influence condition. Male pattern baldness is caused by follicular response to dihydrotestosterone. Treatments now is with Rogaine, minoxidil. That used to be an antihypertensive medication. It didn't do such a good job at controlling blood pressure, but some very astute doctors noticed the people they were treating the blood pressure who had this balding seemed to have recovered hair and doing better. They asked questions about it, and then lo and behold, when the drug company said that this is not going to be really a big money maker as an antihypertensive medication for several problems, But guess what? We got some reports where it's making men happy, that's losing hair and going bald. It improves that. So then they did a little bit of changing around with it and then repackaged it and sold it as Rogaine as a treatment for hair baldness. Nails. They're scale-like modifications of the epidermis. They act as protective coverings for the distal dorsal surfaces of the fingers and toes. Where a lot of animals have claws, but because of those thickened claws and all, they don't have the dexterity, the ability to manipulate things with their what you call hands. So for us to have the end of an extremity that would be more able to manipulate things in the environment, we opted not for claws but for a thin covering that we can use these fingernails to help manipulate things around about. Nails contain hard keratin. The nail matrix is where we're going to see where nail growth takes place. Here's a nice picture, figure 5.3 of the nail. We see the free nail edge, the nail itself, the lateral nail fold, the lunula, the eponychium, the proximal nail fold, the hyponychium, we see the dermis, the epidermis, and then the phalanx, the bone itself. So again, the nail is an accessory structure of the integumentary system. And again, it's one in which a lot of money is spent on. Women like to have their fingernails colored, go and get their pedicure, and also we humans are really fascinated by our fingernails. And of course, from a medical standpoint, we can look at the shape of the fingernails, the coloration of the nail bed, and get an ideal of the general health status of a patient. And with regards to the nails, the nail bed is a specialized structure of the epidermis that is found at the tips of our fingers and toes. The nail body is formed on the nail bed and protects the tips of our fingers and toes. In addition, the nail body forms a back support for picking up small objects with the fingers. So we need better dexterity. What really separates us from a lot of the primates is that we can use our hands to do all of this really nice things that we do as humans. The nail body is composed of densely packed dead keratinocytes. The epidermis in this part of the body has evolved as a specialized structure upon which the nails can form. The nail body forms at the nail root, and the nail root has a matrix of proliferating cells from the stratum bacilli of the epidermis. Remember where this is, the nails is the derivative from the epidermis. So that then the matrix enables the nails to continuously grow. The lateral nail fold overlaps the nails on the side. This helps to anchor the nail body. Now this nail fold that meets the part of the nail fold that meets the proximal end of the nail body forms what we call the cuticle, the nail cuticle, also called the eponychium. The nail bed is going to be rich with blood vessels, making it appear pink, except at the base, because there's a thick layer of epithelium over the matrix, the nail matrix, which forms this crescent-shaped region we call the lunula, the little moon. The area beneath the free edge of the nail, then further from the cuticle, is the hyponychium. That's where we say that we pulled the fingernail into the quick. And very painful if we pull that fingernail up. So that consists of a thickened layer of the stratum corneum. Sweat glands, also called sudoriferous glands. All skin surfaces, except for the nipples and parts of the external genitalia, will have these type of glands. The two main types, eccrine, which are the merocrine type sweat glands, got about 2.5 million on the body, and apocrine sweat glands, only about 2,000 of those. These sweat glands will contain a special little cell, epithelial cell like a muscle, so it's a myoepithelial cell. So they can contract upon nervous system stimulation to force the sweat into the ducts, then to get the water on top, because while they're there they've absorbed a lot of heat. We want that sweat to come to the surface because it's containing a tremendous amount of heat. Remember, water has a high capacity for heat, and then as it evaporates off, unless we got real high humidity in the air, that water molecule would take a lot of heat away from the body. Eccrine sweat glands, most numerous, simple tubular type of gland, very abundant on the palm, soles, and the forehead. And these ducts these glands have their ducts connect to pores. Their main function is thermal regulation. So they're going to be regulated by the sympathetic nervous system. Secretion is sweat. Sweat, 99% water, got some salt, vitamin C, some antibodies, some antimicrobial compounds such as derpsidum there, and some metabolic waste. Here then is that picture we have seen earlier, 5.14, that shows you the eccrine sweat gland, how then it comes, has a duct, and it's going to come out of the top of the skin, a little opening called the pore. So we'll look here at that apocrine gland, sweat gland, actually like a American gland. Largely going to be confined to under the arms, the axillary, and around the anus and genital, the anogenital area. Only about 2,000 of these per average on the body. Made of sweat. Fatty substance and protein would be its secretion. That secretion then appear viscous, milky, or yellow. Usually odorless unless there's some bacterial interaction with it to give a particular body odor. They're larger than the eccrine sweat glands. Their duct is going to empty into a hair follicle. Usually these don't become functional until around puberty. The actual function for them we don't really know or appreciate now. At this time they may act as sexual scent glands and all. People say, boy, I just like how this person smells, for example. Something about just their smell I like. We can talk about some modified apocrine sweat glands. Earwax, ceruminous glands lining the external ear canal, secretes the earwax, cerumen. Mammary glands secrete then milk. Sebaceous oil glands are going to be pretty widely distributed. They're not going to be in the thick skin, so therefore they're not going to be in the palms and soles of the feet. We don't want anything on our feet that's going to cause us to slip and fall. We don't want them in our hands to make our hands slippery so we can't pick up things, manipulate things. Most develop from the hair follicles and secrete into the hair follicle shaft. Relatively inactive until puberty. They become stimulated by hormones in that time, especially the androgens become activated. They secrete sebum, and so they're oily holocrine type secretion. And that gives us some bactericidal activity to it, softens the hair and skin as well. Here, acne is a result of overproduction of a sebaceous gland that can lead to the formation of those nasty old blackheads and inflammation of the skin. So what's the functions of the integumentary system? We can put down as 6: protection, thermal regulation, body temperature regulation, cutaneous sensation, metabolic functions, blood reservoir, as a blood reservoir, and excretion. So when we talk about protections, it gives us 3 types of barriers. It's a chemical barrier, it's a physical barrier, and it's a biological barrier. The chemical barrier, why? Because the skin's secretions, They're usually low pH. That's going to retard certain bacterial multiplication, keep them down in a level that won't become pathogenic. The sebum and defensins there kill bacteria. The melanin is defense against UV radiation from the sun. From a physical barrier standpoint, the flat dead cells of the corneum layer is surrounded by lipids. That keratin and glycolipids blocks most of the water and water-soluble substances and all. It prevents or allows only limited penetration, or hopefully no penetration of the skin from lipid-soluble substances, and a lot of bad things are that. And all. It protects us from organic solvents and salts of heavy metals and all. And certain drug agents. Now we hear about on TV where some of the lawmen with fentanyl and all have to be careful because that drug seems to be easily absorbed through the skin, and even though they're searching through a car, they wind up with a potentially deadly dose of the drug. In regards to the biological barriers, there in the epidermis, we got those dendritic cells. They're going to be antigen-presenting cells to certain white blood cells, the phagocytes of the dermis. They also will be antigen-presenting cells to certain white blood cells in the immune system. We protect the DNA because from electrons and all, it absorbs the UV radiation so it doesn't get to the DNA of the cell. So there it helps to have radiation converted to heat. So body temperature regulation, if the body temperature is in the normal range, we're going to lose about a half a liter to 500 milliliters of water a day through what we call insensible perspiration. We don't even perceive that taking place. Body temperature raises up, we're going to have vasodilation of the dermal vessels and increased sweat gland activity. So we see the sweat, so that's sensible or discernible perspiration. All that heat in that water molecule, unless it's extremely humid outside, it's going to be evaporated off, carrying the heat with it. Cold external environments, we're going to have dermal blood vessel vasoconstriction and try to keep that heat or core body temperature as close to normal as we can. So here the skin temperature drops to a slow passive heat loss. Figure 5.16 gives you a pictorial representation of what we was talking about in regards to thermal regulation. So during strenuous physical activities, the dermal blood vessels vasodilate, sweat secretion increases. We're going to cool the body. We see the reverse happens if we need to maintain the heat and try to not let the core body temperature drop too low. Cutaneous sensation. So here we got those skin sensory receptors, part of the nervous system. They're going to detect temperature, pain, and touch. Skin gives us a metabolic function with the synthesis of vitamin D precursor and collagenase. We have the chemical conversion of potential carcinogens, and it's needed to activate some hormones. Blood reservoir, we can have up to 5% of the total blood volumes temporarily stored there, and we're going to have a little bit of excretion, some nitrogenous waste products, and salt in the sweat. Skin cancer. Most skin tumors are going to be benign, not cancerous, and also that's a good thing. That means they don't metastasize. Risk factors is overexposure of ultraviolet radiation and frequent irritation of the skin from cleansing materials we use and other things. That's because I use gloves when I wash my car, work around the house. Some skin lotions contain enzymes that can repair damaged DNA. 3 major types of skin cancer: basal cell carcinoma, squamous cell carcinoma, and melanoma. Basal cell carcinoma is the least malignant and the most common, and is where the stratum bacilla cells proliferate and slowly invade the dermis and hypodermis. Normally we can cure it with the 99% success rate with surgical excision if people go to the doctor early enough. Here shows a basal cell carcinoma, and it can take several different forms. Squamous cell carcinoma, second most common type, involves the keratinocytes of the stratum spinosum. Usually gives us this scaly reddened papule on the scalp, ears, and lower lips and hands. It does metastasize, but still it's got a very, very good prognosis if treated by radiation therapy or surgical removal early. So here's a view of a squamous cell carcinoma. This was on a person's nose. Here it is on the nose again. And definitely this person has waited way too long to ever let it get to this condition. Melanoma, cancer of the melanocytes. It's the most dangerous. It's highly metastatic, very resistant to a lot of chemotherapies. But now we've got some direct immune therapies added, which we're getting really nice results from the new treatments there. Treated originally with a wide surgical excision accompanied by immunotherapy. Keys to survival of these types of cancers: early detection, the ABCD rule. A, look for asymmetry. The two sides of the pigmented area don't match. B, border irregularity. Exhibits indentations. Color, contains several black, brown, tan, sometimes red or blue. And if that skin lesion has a diameter larger than 6 millimeters, about the size of a pencil eraser. 3 types of skin cancer animations. You can go to that YouTube and learn more about those 3 types of cancers. Eczema. That's a common skin disorder. It presents as red flaky rash, and there's some subdivisions of it. There's some controversy about what causes a person to experience this and all. So if you want to, this is an interesting subject to do some more research on. Burns, that's tissue damage caused by heat, electricity, radiation, or certain chemicals. It's going to denature and destroy the proteins. It kills the cells there. The immediate threat with burns is dehydration of the person with electrolyte imbalances that can cause renal shutdown and or cardiac arrhythmias and all. To evaluate a burn, we're going to use the rule of 9s and use to estimate the volume of potential fluid loss. There's a nice YouTube link to go to and learn more about that rule of 9s and the burns. Here then is calculating the size of the burn from this picture here. So it's the amount of area burn is going to guide the particular type of treatment that's needed. First thing is we got to keep water volume, blood volume in the body. It's that dehydration. Here's another, again, YouTube link to go to and understand the rule of 9. We can classify burns severity by a couple ways. We can say partial thickness burn here. That would be a first-degree burn, epidermal damage only, localized redness, a little bit of swelling, edema, and pain. Second-degree burn, epidermal and upper dermal damage. We normally see blisters here. Full thickness burn, then that's where we have a third-degree burn. Entire thickness of the skin is involved, epidermis and dermal and all. The area of the burn is going to look gray, white, cherry red, or blackened. No pain there that they experience because they've gone down into the dermal area where the nerve endings are, and now they're damaged. They're destroyed, so there's no initial pain. Skin grafting is usually necessary. Critical if, by medical standard, 25% of the body has second-degree burns. Probably going to have a danger of dehydration and later infection. or 10% of the body has third-degree burns, or with face, hand, or feet burn bears third-degree burns and all. Any problem with ventilation, for example, in the face. Treatment includes debridement, removal of the burned skin, antibiotic, appropriate therapy, temporary covering, and skin grafts. Aging. Generally, the skin, especially on the face and hand, will start to display the first signs of aging. It loses its elasticity over time, and we get that chin hanging down, skin underneath the arms hanging down. We have a loss of the collagen fibers. There's a way to try to postpone some of this with being properly hydrated, good nutrition, watching sun exposure, things such as that. There you go. That's Chapter 5, the integument.